Welcome to the Geospatial Decision Making, the South Carolina National Guard data-driven COVID-19 response. We are here to tell you about how we use GIS to aid in decision making during the COVID-19 pandemic. I am Chrissy Jacobs, and I graduated from the University of Georgia with a degree in geography and a certificate in GIS. I've been doing GIS for over 18 years, and I've been with the National Guard for over 12, and now I serve as a GIS program manager.
My name is Kevin Haynes. I graduated from Western Michigan University with a master's in geography and a master's of public administration. I've been doing GIS for 4 years. I've been with the National Guard in South Carolina for 1.5 years, and I currently serve as the environmental GIS manager. The South Carolina National Guard Joint Operation Commander for the COVID-19 mission was introduced to GIS during his missions in Iraq. So it was natural for him to request GIS support to drive decision-making at the onset of the COVID-19 pandemic. A key feature of emergency response is the ability to adapt to a rapidly changing environment. The ESRI software suite allows us to do just that. The ESRI disaster response program provided us with technical support that allowed us to give our leadership the situational awareness they needed to make data-driven decisions. The South Carolina National Guard mission has changed dramatically over the last 1.5 years. The purpose of this presentation is to show the adaptability of GIS and the scalability of the ArcGIS Dashboard throughout the COVID-19 pandemic. We will show examples of the evolution of our dashboard from the early stages of the pandemic when we were only tracking cases to now when we're tracking vaccine distribution, cases, and individual hospital statuses like bed capacity. The ArcGIS Dashboard allows the National Guard to maintain situational awareness even during a rapidly evolving situation. The ESRI Disaster Response Program provided the assistance we needed to rapidly deploy new geospatial solutions that decision makers needed quickly. If you give a general a dashboard, he'll want several apps and 1 million maps to go with it. We will also show you some examples of some other maps and applications we provided during this pandemic.
At the very beginning, nothing was known and everything was rapidly evolving. But the one thing that stayed consistent is that leadership needed answers right away as to where the COVID-19 cases were, how the hospitals were doing in our state, and where we are going to need to send the South Carolina National Guard resources. Our state has an emergency response database of record called Palmetto. This database is where the hospital status was tracked. Once we gained access to this database, it became apparent that we needed ESRI's help because the data was not in a format that was able to be analyzed. We reached out to our ESRI rep and began the process of activating the DRP. We wanted to give the South Carolina National Guard a common operating picture to show mission status, soldiers working on the mission, and COVID cases around the state. There were so many questions around the agency as to how many missions the Guard was working, how many cases our state had. So we decided a dashboard was the best solution to help answer the questions for the entire agency. Our GIS department was not tasked with creating the dashboard, but we knew that a GIS solution would help answer the questions posed at the onset of the pandemic. It started out very basic, showing National Guard mission information on the left-hand side, the COVID-19 cases by county with testing sites in the middle, and COVID-19 cases by South Carolina and the United States on the right-hand side. We were manually inputting the mission information and using Johns Hopkins data for the COVID-19 information. The questions that were constantly asked in the beginning revolved around, how does South Carolina compare to our neighbors? What are the temporal trends? And do we need to activate more troops? So we created time series graphs to help answer these questions. At this point in time, we were doing manual data entry and using Excel tables for the time series data. In April, South Carolina had not been impacted by a huge spike in cases. Our goal was to have the data prepared to start tracking hospitalizations, and at the time we were pulling hospital bed capacity from the Palmetto database. It takes time to move resources and people around the state, and the Guard needed to know what was happening now so they could plan resources for the future. We began to focus on high-risk and vulnerable populations. We analyzed the high-risk, vulnerable populations and overpopulated hospitals to determine critical areas for the future operations to mission plan. The questions being asked at the time were, do we have enough hospital beds? Does the Guard need to open field hospitals? Do the hospitals need more staff? So the DRP helped automate a very complicated hospital bed data, which was dynamically fed via the Palmetto database. The Palmetto developers created a REST service for us, which was greatly appreciated, but we quickly realized that each hospital had multiple points based on the bed type. We needed 1 point per hospital with all the bed types as separate attribute fields, and this layer needed to be dynamically linked to the Palmetto database to receive the data updates. The DRP team created a script that pulled the Palmetto data, cleaned it, and output the data in the correct format. The result produced a feature class with 1 point per hospital and the bed types as separate attribute fields. This script was run multiple times per day to maintain a common operating picture. Once the DRP helped us gain dynamic access to the Palmetto database, we were able to visualize detailed hospital level data. Hospital bed types are complicated. There are many types of beds, and the process for hospitals to report census numbers was not well defined at this point. It was challenging for us to understand the different types of beds and how to visualize the data. There was a steep learning curve for us, having never dealt with public health data. We wanted to visualize the data in a way that our leadership could quickly assess the situation, and we felt stacked bar charts were the best solution at the time.
By June of 2020, it became apparent that key stakeholders needed to specifically address data sharing. Prior to the pandemic, there were no systems or processes in place to create and share dynamic data between multiple agencies, let alone sensitive health data. The phrase that was flying around at the time was, "We're building the plane as we fly it." In June of 2020, teletracking became the national standard for hospital reporting. This new data set provided a plethora of new attributes for us to visualize. The governor created the COVID-19 Unified Command Group, comprised of the South Carolina Department of Health and Environmental Control, DHEC, the South Carolina Emergency Management Division, and the South Carolina National Guard. It was not smooth sailing. Each agency has different missions that require asking different questions and need different data requirements. We had no guiding policy on standard operating procedures related to data sharing between multiple agencies. How do 3 state agencies with different missions collaborate and share data? To answer this question, data teams from each agency began meeting weekly to discuss data sharing, our data needs, and data analytics. We were all having to build professional relationships with each other, learn about each other's priorities, our challenges, all while working on a life and death situation. There was a lot of pressure on everyone. The data coordination meetings helped us gain access to dynamic feature services. Most importantly, we were able to gain access to the new teletracking services. We were able to work through the challenges and build effective working relationships with new level of appreciation for each other. As a result of the coordination between the partner agencies, DHEC enacted the South Carolina COVID-19 Response Plan. This plan included provisions for partner agencies to access and share DHEC data as dynamic GIS feature services. DHEC set up an ArcGIS hub to share all of the data. The dynamic feature services allowed us to analyze and visualize the data per our individual agency needs. Another key provision in the plan and operationalized by the hub services allowed for all agencies to report the same numbers from the same source. Once we received access to the teletracking services and the DHEC hub, the question became, what do we do with all of this data? The ESRI Disaster Response Program was an invaluable resource for us. They helped us visualize the data in a more effective way. Even though we had all the data we needed, it still needed additional attributes to display on the dashboard accurately. For example, there was a field for total beds and another bed for beds occupied. The DRP helped us understand that we needed an additional field for beds not used. The DRP wrote scripts for us to help calculate new fields that helped us visualize the data more effectively. These bar charts show hospital bed capacity. Each bar represents a hospital, and each bar fills as more patients occupy beds. Here's another example of how the DRP helped us. These bars represent hospitals and ventilator usage. We could track ventilator supplies in near real time, giving our leadership the data they needed to move supplies around the state. Emergency room status was another area of concern. We started tracking emergency room visits and COVID-19 related emergency room visits over time at a regional level. When we saw spikes in a region, we would start looking into the hospital level indicators to see what's happening. Interestingly, throughout the pandemic, we've noticed that emergency room visits actually declined from normal pre-pandemic levels. Emergency rooms were seeing less non-COVID related patients, perhaps due to fears of going to the emergency room. After months of strain on hospitals, staffing shortages became a real concern. Guard medics were being utilized in hospitals across the state. This map shows hospitals with anticipated staffing shortages. Vaccines rolled out in December of 2020, but we were still dealing with hospitals being at critical surge capacity. The South Carolina National Guard developed a method of analyzing hospitals in need of medics. Hospitals needed to be above 90% capacity with more than 25% of patients testing positive for COVID-19 to be eligible to request National Guard medic support. The map shows firefly symbols for hospitals that meet the criteria. This data updates twice a day. In the new year, we started tracking vaccine distribution. We were able to track vaccine distribution and utilization at the hospital level. This information allowed leadership to see if a hospital system was in need of medics to assist sticking needles in arms. In January, we started to see COVID-19 related emergency room visits increase on a regional level. Based on this information, the dashboard allowed us to add more tabs to drill down into hospital levels. As we saw emergency room visits increase at the regional level, we saw intensive care bed capacity begin to reach levels of critical concern over 90% capacity. The ArcGIS Dashboard allowed us to visualize and analyze the data at different geographic scales, from regional level red flags to individual hospital levels of concern. The dashboard allowed our leadership to make decisions on resource allocations much more effectively.
Hopefully, the final phase of the COVID-19 pandemic is the vaccine distribution. Once vaccine distribution was readily available in South Carolina, systems had to be put in place to collect and share this new data between agencies. At the beginning of the vaccine rollout, we knew how many vaccines our state received, but there was not a legal mechanism to track geographically where the vaccines went once they left the redistribution centers. There was a major issue determining the utilization rate of each provider and where each provider was located. Another level of complexity was how the data would be analyzed, considering 2 of the vaccines needed to be given in 2 doses and 1 vaccine needed 1 dose. Determining how many people were fully vaccinated became very complex. The Data Coordination Working Group became vital during this phase in order to fully understand how to analyze and visualize the vaccine data. By mid-2021, vaccine distribution is the focus. We're tracking utilization, making sure the vaccine is going into people's arms, and assisting if providers need more resources to speed things up. The mission began to change from sending medics to hospitals for COVID-19 assistance to sending medics to hospitals for vaccine assistance. The right-hand side of the dashboard details all the information leadership needs to know in regards to vaccine distribution throughout our state. We are even tracking internal South Carolina National Guard vaccines received and administered to our own soldiers, and how many vaccines our medics are administering to civilians. The map shows the vaccine recipient rate per county and vaccine locations currently taking appointments. Another way we can visualize the data is by tracking vaccine allocation by county. One way of analyzing the data is when the South Carolina National Guard missions might slow down is to look at the trend of first dose administered by day. When people stop receiving the first dose of the vaccines, the missions might start slowing down.
The dashboard isn't the only GIS solution we've provided during the COVID-19 response. We recognized early on the utility of the ArcGIS space-time pattern analysis workflows. Determining where emerging hotspots are helps the National Guard make decisions on future resource allocation. We reached out to the Disaster Response Program to help us understand the tool settings and ensure we were producing valid and sound results. We conducted this analysis and presented it in the Medical Command Brief each week for several months of 2020. We used ArcGIS Business Analysts to conduct site suitability analysis to determine optimal community testing and vaccine sites. We also produced several web mapping applications to allow agency partners and soldiers the ability to interact and explore the data themselves. We have been producing a series of maps that are part of the South Carolina National Guard State Surgeon's COVID-19 command briefings each week. These maps have been and continue to be created every week since April of 2020.
To conclude, we want to emphasize how critical the ArcGIS dashboard was to the South Carolina COVID-19 response. The dashboard allowed us to visualize and adapt to the situation as needed. And without the ESRI DRP, we wouldn't have been able to produce the solutions that were required to carry out our mission and achieve our objectives. Our leadership integrates GIS into all levels of decision making when conducting normal business. And when an emergency strikes, our leadership knows who to turn to get data-driven answers. And I think the key is that our leadership has been attending the ESRI UC for over 10 years now, and I think this is vital in growing our GIS department. Thank you for taking the time to listen to our story. Feel free to contact us should you have any questions.